So Jerry, also being of the oncology background, how do we get the oncologist more engaged and educated in the use of these rapid onset opioids? And what's the role of the oncology nurse in the clinical management of breakthrough cancer pain?
Well, the two questions are very integrated in my mind, because the oncology nurse, in reporting appropriate assessments and appropriate responses to the medications that are given, can often change the behavior of the physician, because so often they hear the same results over and over. It did work or it didn't work, and so the oncologist will change the practice, his or her practice. So the nurse giving adequate reports about the pain, both at assessment and reassessment, are critical to informing the physician that this indeed works.
Sure. So give us an idea of what your day is like, and what's your involvement with patient care, and who are the critical decision makers when it comes to long-acting, short-acting, rapid onset opioids?
First of all, we do a team approach where I work, and the role of the nurse in that is to first, it's almost before they see the patient, they are wiping the biases off their feet before they walk into that room, because we all tend to have them, and so acknowledging that we have a bias, it needs to stop at the door. And then as we go into the room to do the assessment, it is an unbiased assessment, and it is focused on the physical assessment and the questions that we ask. And also that assessment includes those other areas around pain, like suffering, cultural issues, spiritual issues, and those dimensions of pain that the nurse can then assess while they're in there. The nurse, of all the healthcare team members, probably has more time with the patient than any other. And so the opportunities are great for what can be accomplished. Thirdly is education. But I always caution my team that before you educate, you have got to establish some rapport before you get there. They have to, what's the saying? They don't know how much you know until you communicate how much you care. And so establishing that rapport early on with the patient is critical. And then secondly, finding out what is it that they are afraid of. What do they fear? What are their concerns about their pain, their condition, and their opioids, if that's what they're on, or their medications, and then educating starting there and then moving forward. The reassessment piece is critical, and I cannot stress that enough. We kind of have a rampant disregard for reassessment in nursing in our culture, and so pushing that is important to effective pain management is critical. And then lastly, it's evaluating every patient for risk of misuse or addiction. It is a question that should be standard. We ask everything else about the body. We need to ask that question of every patient.
You know, I'm thrilled you bring that up in the context of cancer pain, because the cancer patients aren't spared from abuse, addiction, diversion, misuse issues. Mark, in your practice, you get to see any of that?
Yeah, no, actually, I was going to just piggyback on what she said. So just a couple things first on that is, you know, the nurse is invaluable. I mean, patients will, after you leave, after one of the nurses would leave, they go to chemotherapy. They don't say anything that they told the nurse. We're not informed, say, because it's a very fast interaction. They get to the chemotherapy suite, and all of a sudden complaints start. And, you know, because they don't want to tell us a lot of things. So you have to make sure that you have that good dialogue with the nurse going in then with the patient. The issue with aversion and, you know, of abuse, there's no question. I mean, patients come from all social classes. There's all issues. So you have to be very careful. And, you know, we're not trained as pain management docs to necessarily look for all these different types of behaviors, but I think we're pretty aware of who to be more trusting and not trusting about.
Sure. So once we're